Good evening and welcome to everybody joining. Today we are hosting Cure's webinar series on the occasion of World Stroke Day. Over the next hour, we will be exploring the role of AI and a physician's insight on AI-powered stroke care. To begin with, we would touch upon the state of stroke care and the challenges in access to timely intervention. We will then hear from our panelists about their experiences working with tech solutions to enable a hub-and-spoke model of care delivery in stroke. Today we have with us Mr. Debojyoti Banerjee from Medtronic and Dr. Paul Alapatt from Aster MIMS. A warm welcome to both of you. Just as a round of introductions, Mr. Debojyoti Banerjee, or Dev as I would refer to him, is the Marketing Director for Medtronic India. He's responsible for strategy, training and education, localization and partnerships. In his current role, he has been instrumental in overseeing changes in the way marketing is perceived in the medical devices organization. He believes that the opportunity to contribute comes with collaboration and not with competition, which is very much in line with the theme for this year's World Stroke Day. He has a keen interest in neurological therapies and strongly advocates for awareness and adoption of these mechanisms to changing lives. He is also passionate about market outreach and was instrumental in creating opportunities for patients with obesity and metabolic health. He has also worked on 4 government schemes across different Indian states. Thank you for joining us here today, Dev. Dr. Paul is an intervention neurologist at Aster MIMS Calicut. He completed his MBBS internal medicine before going on to pursue DM neurology training. Dr. Paul has undergone fellowship training in intervention neurology and is a member of Royal College of Physicians, where he has completed his MRCP in neurology. His areas of expertise include stroke management, especially involving mechanical thrombectomy and carotid stenting. He also has a keen interest in research in various neurology subspecialties. Thank you so much, Doctor, for joining us today. We know you are a cricket fan, and despite the cricket match, thank you for joining us here today. And lastly, I am Anumeha Srivastava. I am the Chief Customer Officer of Qure. Over the last 4 years, I have been working with a brilliant team to drive adoption of our AI products across various healthcare systems. I am also very passionate about the role that technology has come to play for providing an accessible and affordable solution for patients globally. So, looking forward to our discussion today. To begin with, Dr. Paul, if you could, before we delve into the hub and spoke model, if you could throw some light on what stroke care management looks like in India or globally, and why is time of such critical essence in this care pathway? That would be a great thing for our audience to begin with.
Stroke care management in India is still way short of expectations which we perceive. Because stroke care management, we can divide into the acute stroke management or the hyperacute stroke management versus what happens after the first 24 hours or rehab, etc., all those things. So in this talk, we are focusing on the initial hyperacute stroke management. In this, there is a gross unmet need for this hyperacute stroke management. If in our ground reality, if you look out of 100 strokes that come, maybe 1 to 4 come in time and get the exact treatment which is needed. So if you look at global or Indian statistics, they say around 5% they come in time and get the exact treatment what is needed. So the treatment in hyperacute stroke can be divided into what we have primarily 2 reperfusion strategies, because it is very easy to understand. When you have a blocked vessel, you should open the vessel. That is the first thing in the hyperacute. So when you open the vessel, there are only 2 things which are nowadays used. One is you use a drug to open the vessel, or you use some mechanical mean to open the vessel. So mechanical means you have to have a fairly large size of the vessel to open it, because you need something which is going inside that. So you use that for only larger vessels, which are roughly like you have 2 mm vessels. So you use that 2 mm or more, or maybe 1.5 to 2 mm, at least in the Indian scenario. And all the other vessels, you can use the drug, which can reach in every other place. So what happens is, most of the time it is about stroke awareness, because if without stroke awareness, you will not understand what is actually these patients do not know what is actually stroke. Even when you go for a stroke awareness function, which is organized on World Stroke Days, usually the chief guest also will be most of the time calling stroke as a cardiac illness most of the time. So that is the degree of awareness you have. So without awareness, patients do not come to the hospital. So we are actually dealing with not only awareness. What you guys are doing is about the pre-notification and transfer identification to the stroke, and then rapidly delivering treatment. So before that, awareness is also needed. I just wanted to make a mention of that. After that is the treatment, this thing. So most of the time when we, on a ground reality, when we tell about treatment, if the patient is not aware, most of the time they cannot take a correct decision, because ours is a patient paying out of pocket scenario most of the time, rather than an insurance model. Once it goes into an insurance model, things may be fairly easier to convince, because whenever there is payment involved by the patients and they have to take rapid decisions, then most of the time that also becomes an issue for us as a roadblock to go ahead. So even doctors also miss these signs of strokes. I have even neurologists who have missed the signs and who do not come in the first 4.5 hours for minor strokes at least.
Thank you, Dr. Albert. No, I think you have pressed upon a very important point. 1 to 4 out of 100 is a shocking numeric. Given that there are more than 1.2 million patients coming in every year, so the number of patients actually not getting appropriate care, that becomes really high. But because you talk about awareness, I observed that we had some very good videos coming out of Aster and Medtronic both today that have a heavy focus on awareness creation, and I would insist that our audience takes a look on that, because both are delivering a similar message in very different styles to different audiences, and I think that organizations such as yourself can play a very big role in awareness creation.
I just wanted to make one point, because awareness creation by the public, it is the government who you have to make policy changes at the government level to make substantial change. So in stroke, even that, because that is why I'm saying in the chief guest, the health minister comes. Even the health minister may be making a remark like a stroke, equating with they think something is happening in the heart when it is a stroke. So that is the degree of awareness most of the time. So at that time, actually what they do not do is they have to make policy changes from their level, because most treatments even in government hospitals, you can look at how much government hospitals are there in India, including the district and taluk hospitals, they have to have thrombolysis and thrombolytic care and an option for mechanical thrombectomy, etc., with referral. But here what is happening is it is a private enterprise that is actually having in a few select private corporate hospitals who are routinely doing 24/7 correct comprehensive care, and maybe the big institutions in the government. But without instituting it in a ground level, the common man is not going to go for it, any treatment, because you can keep harping whatever you want, you can send videos, but if it is not provided, because when a patient comes with an acute MI, that treatment happens in the taluk district hospital level. If there's a cath lab, they do it there, then they refer it. But even in our state, in Kerala, I can say that no hospital as of today in the government sector, I'm saying the state government sector, I'm not saying central government institutions, have an option for a thrombectomy. So without that hospital, you say that it is 1 in 2.6 improve. This is a class 1 level evidence, say gold standard, etc. But why is a gold standard not being implemented? So you have to have policy decisions to change it at that level.
No, absolutely well received, Dr. Paul. I think the change has to start across from the government sector, and private sector can come in to support as well, which is so I think it goes both ways. But that brings me to talking about what is the overall burden of stroke care in India, and Deb, if you could throw some light about how many patients should be getting mechanical thrombectomy, which Dr. Paul briefly touched on.
These are just whatever I'm going to say. These are just based on a few studies, and these studies are done in academic centers, and you may miss out on a lot of patients. So out of this, what is said nowadays is an Indian is getting 3 Indians are getting strokes every 1 minute. That is 1 every 20 seconds. and one person is dying of a stroke every 3 to 4 minutes, and there are around 15 lakh strokes a year. So if you look, usually a ballpark figure of 20 to 25% of large vessel occlusions or large vessel disease at least. And so you are missing around maybe 2.5 to 3 lakh mechanical thrombectomies. Medtronic or the device industry can correlate how much devices are used per year regarding this. And then you have around 3 lakh options for mechanical thrombectomies, maybe an year in India.
And that is a huge population going into chronic disabling conditions. Thank you, Dr. Paul. Deb, do you want to throw some light about how you see it from the medical device space? Because Medtronic has been working in this space for a long time. Could you throw some light about possible reasons for this large burden? And if you would like to, then a little bit about the hub and spoke model in India as it stands today.
Yeah, sure. Thanks for making me a part of this interesting conversation, actually. Typically, if you look at it, I would say approximately about 30% of the stroke patients, they have actually large vessel occlusion. So basically, they are eligible for mechanical thrombectomy. And it is estimated that less than 1% of the eligible patient population actually gets that treatment. Okay. Now, there could be various reasons, but the top of the reasons that come into my mind when I look at the reasons as to why this is such an addressed area, the first thing that comes into my mind is awareness and education. I think there is still a lot to be done in terms of ensuring that people are aware of the condition. They can look at the symptoms of stroke very seriously and then take action in that critical window period. If you look at the access or the infrastructure that has been provided, which can actually help in terms of providing this, is present. But then there is a very critical piece of information which needs to be understood, that approximately 2/3 of the eligible patients actually get treated in roughly about 10 cities across the country. Okay, now when you have 2/3 of the eligible population which is getting treated in 10 cities, effectively which hosts about 1/4 of Indian population. So roughly about, if you do the math, about 350 million people you have been in 10 cities, and those 10 cities actually can do 2/3 of these cases. There's a huge unmet need. There's a huge area wherein people are not getting the treatment, not getting that access to the treatment. Of course, as Dr. Paul also mentioned, affordability is also a concern, because you have most of the cases happening as out of pocket. You don't have the insurance coverage largely. However, what I given to understand is that mechanical thrombectomy is now covered under Ayushman Bharat scheme. So effectively, you have, number one, lack of awareness on the part of the patient. You also have infrastructure and access issues, because it is highly polarized in terms of centers which can actually deliver the care aspect of it. You have an affordability situation as well. And most importantly, you do have the polarization of centers being available at a particular place. So the critical piece is that hub and spoke model is possibly the only way forward through which we can address or create a situation wherein these patients can actually get access to the care. So that's predominantly the thought process behind it.
Thank you, Dev. Just to elaborate the word, we often use hub and spoke. Basically, what hub and spoke model means, and this is in use in various industries, but in the stroke care, what it means is, like Dr. Paul was mentioning, comprehensive stroke care is available on only a handful of centers. So how can we allow patients in these spokes that are slightly distant but have the correct mechanisms or the knowledge or education to triage patients to send them to hubs to avail timely care is the whole idea. And as Qure and as many other technological partners, we are trying to enable this movement very quickly, because in the absence of a formal referral mechanism, there can be many other challenges in moving the patient from the spoke to the hub. But that brings me to my next question, and this is something that as an intervention neurologist, Dr. Paul, you can throw some light on. A lot of this is very little understood and definitely very early in the adoption stage. both from a current mechanism, a current scenario perspective and future, could you tell us how is the hub and spoke model improving care, or how do you see it improving care, and how is this care coordination that I was talking about between these distant hubs and spokes happening today? If you could tell us a little bit about it, given you have used this technology, we would love to hear from you.
So this hub and spoke model has always existed
Right.
from years, but it is just an informal, and you do not call it, because it is just basically there is a person who sees in a primary center and they will refer, but to the and it will be through, you can through a phone call, etc. But stroke, what happens is you need rapid assessment and rapid transfer, so you cannot wait the next day. So that is why in stroke, this hub and spoke, we have to call this hub and spoke, we have to formalize it, we need a good workflow, we need to train people on in this spoke, how to come to the hub, etc. So when the hub and spoke model, as of now, we have a hub and spoke model which we have implemented, and that is a model in which we also train our primary stroke centers on how we. Initially, what we had done was we went to the stroke center, we did an audit on where their gaps were, and then we filled in those gaps, and we did frequent visits with coaching of these centers, because most of these spoke centers will not have neurologists. So basically, we have to give them the confidence and the know-how. Most of the time, stroke is a very simple disease to treat most of the time, because the patient comes, everything is over in half an hour. So you have to just make a diagnosis of stroke, and you have to give the drug. You need to know the contraindication. It is like how you need a checklist. So how you fly an aeroplane, you have a checklist. So the checklist has to be coming through, and with the recent hub and spoke model and with artificial intelligence helping, that is where artificial intelligence also comes in, because in artificial intelligence may not help maybe in the high volume centers, in primary stroke center where already a system is in place to see the images and you see, but in these spoke centers, they can, with people who, there are no radiologists around the call, there are no even physicians, there may be emergency physicians there in the ED, so they can see, and once something is flagged, they know that it is a stroke, they see the CT, they get more comfortable. The CT is seen at the same time by the physician, by the person in the hub, and they give the directions, and with the help of the directions from, because even in our centers initially they used to give the ask us for the directions, and slowly now we find that they do not ask us for directions, they can thrombolize and they get more confident, because thrombolysis, even for a neurologist, your initial thrombolysis, when you even pass out, you have your stress levels which are high, and then as you grow more comfortable doing more cases of thrombolysis, then most of the people learn. It is if you do it in the correct way, the chances of complications are less, and we are here to support there at that time. So they refer these from these spokes to the hub. So we have five hub spokes which we have identified around us, and we most of the time even we find actually in the hub large vessel occlusions, maybe it is less, but we can thrombolize a lot of these patients and reach stroke care, because what I have found in stroke personally, the first 1 to 2 hours is the maximum important, not the cases in the first 4 to 4.5 hours or 3.5 to 4.5 hours, because by the time most of the patients have a lot of damaged tissue and the risk of bleed is high. So where the first hospital they are going, there is where you have to thrombolize. And then so with this hub and spoke model, that is the most, at the first place where they go, you should thrombolize. It should not that they should come to the city or they should come to the main center and thrombolize. Then it is not going to work. Even however big the hospital, if the brain tissue is infarcted, there is no use of thrombolysis. It is not just you reach by 4.5 hours. You should reach by 1 hour. So your outcomes are better. So this hub and spoke helps in that way. Then second, all these patients, all these what these hospitals complain is, this patient deteriorates, this patient does not make it, patient is not improving. So these usually what we find is that 20% which we told about earlier, the large vessel occlusions. So this hub and spoke, especially with powered by AI, which can detect large vessel occlusions initially. So whenever we finish the CT or the angio along with it, the AI tells, or the person on the ground tells it is a large vessel occlusion. The spoke doctor knows it is a large vessel occlusion. This patient is not likely to do well with thrombolysis, or may have a bad course, and can inform the patient relatives prior to that this is going to be bad, but still we have to give this drug because this is only chance. Most of the time the patients attribute the drug to everything, but that is the disease course. And I always equate it like a runaway train which is going at 100 km/h. You do not stop it initially with 100 to 0. You put a brake and then it goes 90, 80, 70, and you can stop at 60, 50, and so the patient will say that the disease is still there, but we have actually slowed the speed of the train, of the damage which is happening. That the patient may not appreciate initially as evidence in the this thing, but even the studies show all these outcomes are at 3 months. So we have to wait till that 3 months and see how it is. So hub and spoke helps in both ways. That is for the thrombolysis and the thrombectomy.
Thanks, Dr.
And
Paul.
even
That's
also
very
the medical legal, one more medical legal aspects, because if it is an approved app, when we are using an app which is approved rather than WhatsApp, a lot of the time when we usually have WhatsApp images and also both coming together from other centers so the quality of the images very much matters in this. So the image quality is very high when you are going through a formally recognized app rather than WhatsApp, which is taken at different angles and different views depending on the person who is taking it, and you can make wrong decisions, I'm telling you, based on CT, especially the aspects, etc. So the hub and spoke helps in that also, personally.
Right. Thank you so much, Dr. Paul. Let me, for the help of the audience, I will share that there is a chat box here. I know some of the conversations that Dr. Paul is sharing might be complex to understand for non-medical teams, so please feel free to ask your questions. I would also like to take a few seconds to describe what Dr. Paul was mentioning. So the care coordination platform that Qure provides allows the hubs and the spokes to see the same digital image, whether it be a CT scan or an MRI, on the application, and the quality of that image is a lot higher than traditional mechanisms that are often used, which are WhatsApp or mail. And this allows the physicians and the neurologists and radiologists on both sides to see and make a very accurate and measured decision around the image, and also seamlessly communicate within the correct GDPR and HIPAA laws within this tool, so that the patient privacy and the data is very at the foremost, and still there is no delay or lag in the patient moving between the hub and the spoke. Deb, I would like to ask you about what your experience has been as Medtronic. I understand that Medtronic has worked with AI technologies to enable such models elsewhere as well. So could you throw some light about the thing that you were mentioning earlier, that if 10 cities is where most of this is happening, then there is a big question on equity, because 70% of India lives in its villages. And then if everybody is getting treated in the bigger cities, then we know what is going on there, and there is differential access to care. So could you tell me a little bit about your experience as Medtronic working with AI technologies, and how do you see this evolving to make hub and spoke care better?
So I think, the way you explained actually, and even Dr. Paul augmented the thought process of hub and spoke model. I think one of the important aspects is that the crunching timelines, okay, and how best we can actually utilize the entire technology in terms of identifying and possibly treating it at the spoke. Okay, so effectively, if you see, and we have had examples, allow me to share a story from Gujarat actually. Wherein there was a patient who was identified close to about 7:50, 7:45 in the morning, that there was an issue, and we actually received the details from a spoke center, and all the stakeholders were alerted. The patient actually received a primary treatment, thrombolysis at the spoke center, and then was mobilized to the hub center and got a mechanical thrombectomy by around 10:45. So effectively, as we were saying, that the timing is such a critical aspect, and the way we actually get these P's sorted at the hub and spoke model, that you get the preliminary treatment at the spoke and then you transfer them to the hub so that they get the complete treatment done, is working phenomenally well. And that's happening primarily because we are able to utilize the entire artificial intelligence thought process and how we can actually get the pieces sorted. Typically, if you look at our ability to see how as an organization we are being dedicated towards this cause, and how we are taking multiple initiatives. So if you look at it, we are equally focused and interested in ensuring that the bridge in between the hub and spoke is absolutely sealed through AI. We constantly believe that it could be a critical game changer in the stroke pathway. It can crash down timelines significantly. And of course, we also have the thought process of how best we can utilize and scale up the hub and spoke model so that more number of patients can get treated. And the 10 cities that we're talking about, wherein there are multiple number of centers which cater to 2/3 of the population, possibly 2/3 of the eligible population, we have to scale it up. We have to see how best we can make it wider, and the hub and spoke model can also help us serve more number of patients across.
Yes, that makes complete sense. And thank you for sharing that example from Gujarat. I have a very interesting question in the chat, which is related to what you were saying, Dr. Paul, about you seeing that the non-trained neurologists or the younger neurologists and general physicians, you've seen an increase in confidence. One of our audience is asking us that stroke is not new, and how are GPs equipped or trained to identify stroke? Dr. Paul, because you were talking about the recce you had done and how you had educated or worked hand in hand with some of these spoke centers, could you share your experience in this regard, and then I could add something to it as well?
So most of the doctors, GPs, most of India is trained in government hospitals. So even when we are trained in government hospitals, we are, because it is not happening there at that time when it is trained, this thrombolysis, thrombectomies. So if it is not happening, you are not trained. You do not have the psyche of how to do. The psyche is all about time. So the time of psyche is not there. So if you are not seeing that during your training, so when you go out and you are not doing those, then you doctors after if you finish your by GP, you mean after your MBBS. So so they are not actually trained to have. The training is not in the knowledge of the identifying stroke, or that stroke is this. You can make a lot of complicated diagnose. You can tell where the stroke is. You can examine the patient thoroughly. But the most important thing is the importance of time and what is the importance of this treatment. So that does not come into the psyche of doctors when they are trained, because most of that they are trained either pre-thrombectomy or IV thrombolysis era, or even in this era, most hospitals in which they are trained are not offering that treatment in 24/7 100% coverage, or they are offering selectively treatment just as and when the supply is provided. So they see patients who are not being treated like that, and maybe they think that as well, if you do not treat also, it does not make a difference. So I feel that most doctors do not have the psyche, and even among neurologists also.
I understand, and that is unfortunate to hear. I hope that tools and technology can help make that more accessible. But I also wanted to share that my experience is also that a lot of the doctors in India are trained on the job. So if they are posted in a geography or region with high stroke burden, they often end up learning from their seniors or the other faculty at their hospital. And that's when the psyche that Dr. Paul is talking about truly gets internalized. Dr. Paul, another follow-up question on that. Do you see that this hub and spoke model can allow fast-tracking this learning or this experience building? Because I don't want to be leading you somewhere with it, so I'll leave it at that and see what you have to say.
No, when you have a hub and spoke model, the advantage is a lot of people can learn from the spoke, means when they are in the spoke and not only in the hub. So if that is being followed, you have more exposure to what is actually happening, these the spokes. So if in the spokes, the doctors learn more, they are empowered more. And I feel a few months, as I said earlier, a few months of this hub and spoke model, any doctor will be able to do it. Because in the UK, if I'm not mistaken,
Right.
most doctors who are said stroke physicians, they just have to after MBBS there's a special degree. I'm not sure about this, but they do this and they are called stroke physicians. So they are the ones who handle all the emergency stroke thrombolysis and who refer for thrombectomy or who decide, I think, who's taken. It is not the neurologist as say, because they are seeing OP cases most of the time. I'm not 100% sure, but this is how, because I see a lot of stroke physicians. So they are the ones who treat, and so you just need limited know-how, because stroke is a very simple disease if you think simply. And so you just need that approach and the protocol to be followed.
Like the checklist, the airplane checklist that you were talking about.
Just like the airplane checklist, because however big pilot you are, you have to go through the checklist. You have to know which switch to put in which order. If you're not putting in that order, you have to tick, then put again. You cannot be a superstar and go on, I'm going to fly this plane. It's not like that. It's a checklist. Even for thrombolysis and even for thrombectomy, you have to follow the checklist.
That makes sense, yes. I wanted to ask you, have you seen any overall increase in acceptance to AI? AI is such a buzzword right now, but it's not as new as the buzz is. So if you could throw some light on what you are seeing in terms of AI adoption or openness in the market, or the impact of this in resource utilization today, that would be very helpful for our audience.
Yeah, I think there is a definite uptick of the entire situation. We see significant amount of adoption with regards to this particular initiatives being taken place. If you look at our ability to actually gauge in terms of the uptick process, I feel that it's growing at such a rapid space that awareness is gaining momentum. We also have significant amount of situation wherein people are able to recognize this, and it is not that the algorithm might be very different, but at the end of the day the process is very simple, and when you actually explain it or make people aware of it, I think it's working beautifully well. So I look forward to a larger concept of how this can actually bridge the gap even faster and more effectively.
Right, absolutely. To Dr. Paul, I think you can add to that. Have you seen, like they've said, the process is simple and the care coordination tool can help build efficiencies. Have you seen any impact on your workflows? And do you have any patients or any stories from your own practice that come into your mind as you're discussing the impact of AI?
No, we have a lot of stories, so it is too much to be told. So I'm not telling a single story, but last time I was in the OPD, you are talking with respect to only the hub and spoke, which we have used, right?
Correct, for now,
with
yes.
AI. So like we had thrombolysis. One of our spoke centers is the Shanti Hospital, which is in a rural area called Omacheri, like 1 hour away from us. So there we get routine use of this hub and spoke model. And the patient I saw in the OPD maybe around 6-8 months after admission, and the patient's wife was saying in Malayalam that people are asking us how you could come to this hospital and take such a dangerous treatment. What guts you had at that time to do? How foolish were you at that time? But we still went ahead with that, because most of the time when they go to rural centers and they tell about this prognosis that the patient has a 1 to 4% chance of a bleed, and the patient has without a neurosurgeon, etc., it requires guts from the doctor there and the patient bystanders there. The patient most of the time we cannot explain that much. It requires a lot of guts. It's very easy to sit in a big center as us and say that you can do all this and this thing. But on the ground level, when in a very resource poor setting, to give this drug by the doctor and by the relatives who agree to that, they are actually the real heroes. Because even if we actually are there, if I am also there and my bystander or someone gets a stroke there, I would also be circumspect. Do they know what they're doing? They're going to give this treatment, and they are saying that they're doing it through some artificial intelligence, all those. And it is like rural area. So go ahead, and that this patient actually came walking. Went walking. He came with a grade 0 power in the upper and lower limbs, and he went walking from the hospital in 5-6 days after thrombolysis, and he still comes to our OPD regularly. So this is said by the wife of the patient at that time. So that is one thing which really hit me at that time. Like these people are actually having boundless courage to trust to give such a treatment there, because whatever said and done, it is a center which is rural, and in Kerala it is not. A rural area also means that you are educated, everyone is educated, and they know things. So so that is one thing which I would like to share with you.
No, that is truly heartwarming. I got goosebumps as you were describing it. I have worked as a physiotherapist for many years, seeing chronic stroke care in my therapy, and people who's come with complete flexion deformities and would not get better that easily. So this is quite a story of, quite a magical story.
One more thing I always like to add is, someone is having disability, severe disability at onset. Sometimes I like to take that. I feel that they should take the risk. It may be a controversial statement to make, but in my sir also used to say, an MRS of 6 is always better than an MRS of 5 or 4. I don't know if you get what I mean.
Modified Rankin Scale of 6, which is not
MRS
there,
of 6 is the patient is expired. So it is better than, means if you get a stroke, and my sir also say, if I get a stroke, I want to be either an MRS 6 or 1, 2, or at least a 3. I don't want a 4, 5 with people caring for me. So
yeah, that's a very hard reality, but I understand where that comes from.
It's a controversial statement, but that is what people feel. I don't know the ethics of that, but
yes. Let's not get into the details of that, but I understand the sentiment. It is a very difficult place for the families to be in, to see either unwell or severely unwell patients. We have a very interesting question coming from one of our audience. AI adoption in stroke care in India seems to be in early stages. What are your recommendations for policymakers and healthcare institutions to facilitate widespread adoption of AI for stroke care in India? I think both of you can share some light on this question. It's a pertinent question for the session today.
So I think I'll take a stab at it first.
Please do.
The entire policy making, I think, in our country happens on two quantums. One is the level of advocacy and the frequency of advocacy. Okay, so to which portion do we can reach, to which other stakeholders whom we can convince, and the number of times we actually knock on their doors and try to convince them on what exactly is happening. If you look at it, for quite some time, India had a healthcare infrastructure which was not supportive of many of the treatments that would actually save lives. Today, that is a history. I mean, we have scaled up infrastructure to such a huge extent, even during the time of pandemic, or even prior to that, and even after that, the kind of investments which are being made by the healthcare policymakers is significant. But they also need to be informed of what are the new emerging trends. As one of the participants, I think, mentioned that stroke is not new. It is correct. Stroke is not new. But today we have mechanisms of trying to educate people on how it is happening. So at Medtronic, I can say that we had developed a very simple mechanism of how fast. So just remember the word fast. Okay, so if you have a face which is drooping under any circumstances, if you have an arm or a particular limb which is not functioning properly, or you're losing strength out there, or if you have any other symptoms, a speech which is getting a little blurred, so the chances are bright that you're possibly going to have an experience in stroke. Now, how fast can we actually disseminate this information? How fast can we actually educate so many people around? And we can make the policymakers aware of the situation of, like, there's the third time possibly I'm mentioning, how 2/3 of the eligible population of stroke ailments is actually getting treated in those 10 cities is phenomenal. And it's the only option for us is to knock at the door hard and knock at the door multiple number of times to make these things work. Okay, I mean, open to hearing Dr. Paul's views also on that.
I will. What you said is exactly correct. I would just tell the practical aspects of AI as you face it on a day-to-day basis. AI, look, anything you are offering someone that you are going to replace, it will be initially met with resistance. So AI is replacing a lot of things in a lot of places everywhere. And one of my mentors had said this, that look, medicine, you see, the medicine paradigm in which your patients are treated has not changed from time immemorial. You go see a doctor and then you are treated. For anything else, rapid changes have come. Like if you look, initially there were CD cassettes, then there were CDs, now then the movie theaters have gone into, so this industry keeps on changing. So your medical industry is one of the only few industries in which it has not changed from time immemorial. You go see a doctor in the clinic and you see. So, but AI is the one thing which is going to change that in the next maybe 10-20 years. So that is the first. There will always be a bit of resistance to AI when it comes, and whenever someone because initially it is not going to be correct. It is not like Chat GPT or Bard. When you see good answers and everyone goes wah wah, and then it is good. But here you need it to be correct. You need it to be precise. So it's not going to be correct and precise initially, as it is also now. It is not correct and precise. So people will pick on the mistakes. So you have to actually implement it in care models rather than you are with doctor supervision, and rather than you do it keep on doing it in the lab or wherever you are practicing it. So in the current scenario, also in stroke care, you cannot fully rely on an AI this thing, but the AI, especially if it is 3 a.m. in the night, you get a call and you have an AI augmented thing, and then if you are missing something or you're too tired or you're not, and when the AI flags something, then it becomes of great use. You know the aspects or the large vessel or this thing, and you somehow miss it because in your night, you're human, it's 3 a.m. and the next day morning you look 6-7, oh my god, I missed this, and that was that. So there are scenarios which help, but when you are alert, a good functioning human at morning, maybe the human is at this time, at least in stroke care, a bit on the higher side, but I think without starting it does not. And I feel that even in predicting, my most important thing is no one can predict how this patient is going to do. So I think this AI algorithms in the future can predict the long-term outcome of these patients. So that is the most important thing I feel, how this patient is going to do, and if that becomes correct, because no one can say what this patient is going to do, how this patient is going to do. So if you can feed in some data and tell in the future how this patient is going to do, that a human cannot predict, maybe the AI can predict. So AI has to improve, but there's a lot of potential, I feel, to implement it as a treatment in a hyperacute stroke. You need it to be very precise.
Absolutely. I think both of you covered a lot of ground there. But what I hear is very similar to the theme of this year's World Stroke Day. It says, together we are larger than stroke. I believe there needs to be implementation, and physicians such as yourself, Dr. Paul, I truly appreciate them for taking that first step in a new technology where there is resistance. People such as yourself coming forth to generate that evidence and then collectively knocking that door again and vigorously possibly can help us make that policy change that is needed. And as Qure team believes, we are here to strengthen the physician and the radiologist. I think there is so much to solve for together in healthcare that there is no question or need for fear or replacement, but more of can we be a better second pair of eyes or a support or a guide when there is not enough skill or support that the health system has. And that is truly what we envision to do here. I see one quick question for Dr. Paul. If you could tell us, are there geographical pockets in India which have higher stroke incidence? Anything that you know about that over the last 10 years? And I don't want to put you on a spot, but you can share based on your understanding.
Geographical spots, I think India research is fairly underrepresented. So if you have the institute, so they will do a study on their aspect and they can show an increased incidence. So sometimes you see there are a lot of hemorrhagic strokes which are more common in the eastern side of India, in West Bengal, and the eastern side you say. you have in our part of the world, in Kerala, we have a lot of patients here in Malappuram, Kozhikode, here in these areas, where patients are educated, but their diet lifestyle patterns are not that good. You have a lot of ICAD, intracranial atherosclerotic disease. You have Asians, India, with having a lot of ICAD. These and all are due to, I think, rather than a genetic or this thing, I think it is due to mainly lifestyle factors, and us adopting a more westernized diet with lack of exercise, and because when we are adopting a westernized diet, I always feel we are doing it unscientifically, because when the Westerners have given us this diet and they have gone back to the other diet and going back to exercising and all those, and we very uneducated, when I go through a railway station or anywhere, if I want to buy some healthy food, it is not at all available. You have some fried food, you have these chips, you have all these Coke, Pepsis, everything lined up. If I want to drink something or anything, I'm saying in a normal. So actually, it's the poor people who are having this poor diet. Actually, the rich people can afford to go to somewhere and buy a healthy thing or something like that. But nowadays, you see in the common shops lining across the street, you have all these only chips and this thing. So I always go for lifestyle rather than these pockets. So if you have bad lifestyle, whichever pocket it is, you will have that. And there are pockets which are more in the urban centers, but I think the rural centers will be underrepresented.
Yes,
and India is too large this thing to say about a pocket.
Right. So I think there is a lack of national registry and statistics reporting, so that leads to our rural areas being underrepresented. I'm conscious of the time. We are coming to the end of our session, and I thank the audience for the questions they've asked. But just to wrap up, if you could go around the room talking about our vision for AI and the hub and spoke model for stroke care. Maybe just we could throw some light on behalf of our organizations or individually on where we see ourselves going. That would be very helpful. Deb, if you would like to start, and then I'd ask Dr. Paul.
Yeah, sure. So let me bring up an example which was possibly unheard of around 3-4 years back, which is the cashless economy. Okay, so 4-5 years back, I think India was operating under cash or credit card or something like that. Today, you see vendors of all types, cash points at all types being converted into QR codes. And you don't have any banking transaction fee, or you don't have any other fees to actually make that transaction. So it took some time, but technology has helped and aided a lot of people in a very different way. I see a very similar revolution which can be brought in through AI, specifically in healthcare. And I am a very, very firm believer that instead of resisting it, if we try to adopt it as quickly as possible, it's going to only and only improve the way we look at our lives. Completely echo Dr. Paul's views of how lifestyle is actually a problem. It's not actually the location or possibly your lineage or your, where do you stay and stuff like that. But the critical piece is that awareness, detection, and then treatment. And those three things can be merged, can work beautifully if we adopt to those things. Yes, it is not near perfection. No problem with that. Let's make it work. And that's how things are going to become better. I'm sure when we have a webinar, maybe 2 or 3 years down the line, we will have a far more increased awareness. We'll have a system which works a lot better. The timeline that I mentioned of 3 hours of patient being treated, it could be as less as 1.5 hours. So that is the beauty, and that's what we can actually look at, and that is what as an organization we should collaborate and create. That's my take on the entire situation.
Thanks, Deb. Yeah, absolutely. Dr. Paul, also want to hear your views and vision.
Yeah, before that, I would like to first of all put on record my thanks to Medtronic, because we are collaborating a lot with them, and for their passion towards stroke care and helping patients. It's actually helping patients. So and also the Qure team for their passion to develop a product. And I feel there is a long way to go to reach there, and our targets are not met. And as you said, I was very much interested by the example you gave by the cashless. So no one expected it to be that far, this much cashless, this thing. So that is like beyond prediction, maybe COVID or whatever, but it just happened. Someone has, so you have, that is because maybe our Prime Minister has implemented it so fast. So something like that, someone has to implement something like a blanket thing, and then it comes. So there should be will from the very top, and then we can follow.
Absolutely. No, thank you for both for sharing your vision. If I were to add from Qure.ai, as a company, as you said, we are very passionate, we're very enthusiastic, and we're constantly willing to learn and evolve. Because as the policy evolves, there also have to be very robust tools that are actually able to deliver safe and trustworthy care. Our goal is to touch 1 billion lives, and with stroke being the second largest cause of mortality and morbidity, we cannot achieve that 1 billion lives touched without meaningfully solving for stroke. So very excited to be a part of such a beautiful collaboration with Medtronic, with Aster MIMS, and a lot of other similar healthcare organizations doing a lot of meaningful work for stroke. But thank you so much on behalf of the entire Qure team for joining us in this discussion, bringing forth your point of views, and also staying connected with us in this collaboration. Thank you so much.
Thank you.
Thank you. Thanks a lot.